hi everyone. You've got the Office of Affordable Healthcare team here in the room, just us so far. So Meg, Katie, Kaylee, because I know it can be hard to see on the small screen. I know we're waiting on a couple other advisory council members who I was expecting to have joined, but why don't we get started and just have folks do some quick intros so we can keep track of who's on and see if they join in that time. And otherwise, we can jump in and get started. So I'll just do like a quick roll call and if everyone can sort of see here. Sorry, Katie, I think we were getting some background noise just then. It looked like it was coming from your computer, so just a heads up there. I'm not sure. It just popped up for a second. So perfect. I will go around the horn, and if folks can introduce themselves who are advisory council members, that would be great. And I'll just go in order of who's on my screen. So Amanda.
Hi, everyone. I'm Amanda Burgess, and I kind of fill the research seat, one of the research seats in this group, and I'm part-time faculty at the University of Southern Maine Public Health Program.
Wonderful. Thank you. And Richard.
Hi, everyone. Can you hear me?
Yes.
I'm getting feedback. I'm Dr. Richard Evans. I am a recently retired general surgeon in Dover Foxcroft.
Wonderful. Thank you. Katie.
Hello, everyone. Katie Fulham Harris with Maine Health. And are you still getting feedback?
Nope, we can hear you perfectly now.
Great, thanks.
Thank you. Kevin.
Hey, good afternoon. Kevin Lewis, CEO of Community Health Options.
Thank you. Randy.
Hi, I'm Randy Clark. I'm the president of Northern Light, C.A. Dean, Mayo, and Sebastian Valley Hospital.
Perfect. Thank you. Representative Ann Graham.
Hi, good afternoon. I'm Representative Annie Graham, and I serve the people of North Yarmouth and Gray in the legislature.
Thank you. Glad you can join us. Maureen.
Good afternoon, everyone. Maureen Hensley Quinn, Senior Program Director at the National Academy for State Health Policy.
And Kate.
Hello, Kate Endy. I'm the Policy Director of Consumers for Affordable Healthcare.
Thank you. And I know Trevor was expecting to join, and I'm just going to double check. We've got one phone number on. He might be muted. Yeah, that is Trevor's number. So give us 1 second, Trevor, and we're going to allow your microphone. Perfect. So I think you should be able to come off mute and introduce yourself if you want to test that, Trevor. Hey, we can hear you.
There we go. All right. Hey, everyone. I'm Trevor Putnocki with the Healthcare Purchaser Alliance of Maine, and I'm the chair of this committee. Happy to be here.
Perfect. Thank you. I think that covers it for advisory council members. So if it works, I will jump right in and start the presentation. Well, I wanted to start today with a little administrative update. It's a very bittersweet one that I wasn't not excited to share, but we're anticipating that both Katie and Kaylee are going to be leaving the office this summer, both for very good reasons, which I'll let them tell you about, but very difficult for me, going to be challenging. So we wanted to make sure to kind of tell this group, while we had you all together and give a heads up about that. Certainly in terms of next steps, as we're thinking about finding new folks to join the team, we'll probably turn to this group for some help with that recruiting and with sharing posts and things. So more to come on that. But again, just wanted, given the relationships that you all have built and gotten to know them, to that in person. So with that, I'll pass it.
Yeah, Meg, I just wanted to, sorry.
Oh, sorry. I was just going to let them share kind of where they're headed, Trevor, if that's okay. Okay, perfect. So Katie, you want to give a little update?
Absolutely. Good afternoon, everyone. I am seriously considering attending medical school coming this will be in the summertime. Very sad to potentially leave, but I will finalize that decision in the next couple of weeks and keep you all updated. It's been a pleasure seeing you all and being and working in the office here.
And then Kaylee?
And I will be attending grad school at Harvard to get my master's in public health also in the fall. So it's unfortunate that our timing lines up with Katie, but really sad to be leaving the office and really appreciate all of the work you all do and have contributed to our work.
And just on my behalf, definitely, it's like I can't be, too sad because I'm so excited for the next steps that both Katie and Kaylee are planning to take on, and obviously think about new and different ways that they will contribute to making the health system better. I'm just so grateful for their work. I just can't imagine the office and the team without them and without their contributions to get things stood up. So there will be more to come. Like I said, this is also with a great amount of lead time, which I'm very thankful to them both for, given the circumstances. So, nothing immediate, and you'll still be likely hearing from them for a little while we work through the transition. But yeah, wanted to share that news with all of you directly. So then, in terms of other updates, there's one other administrative update that's just a very small, simple one, much less monumental than that, which is that we are actually moving into our new office space today and tomorrow. Folks who have been with us from the beginning might know that initially the office really wasn't funded to sort of have a permanent space. So we bounced around a little bit. We were in an otherwise abandoned state office building for about the first year. And then for the past couple of years, we've used a few extra desks here in the headquarters of the Department of Health and Human Services. But looking to the future, I really wanted to make sure there was kind of a stable, reliable home for the office. So we were fortunate that last year in the biennial budget, the legislature funded us to have some money for rent on an ongoing basis and to cover some expenses associated with the move. So we'll be heading over to 45 Memorial Circle. It's a lot of folks call it the Freddie Flaherty building, right on the roundabout as you come towards the State House here in Augusta. So we are not moving far at all. We can basically see the office from wherever we are right now. Will be great to kind of continue allowing us to easily interact with legislators and with the department. But yeah, that is underway. Just furniture was delivered and assembled today, and then we're moving the last of our stuff tomorrow morning. So no major impacts for now for the advisory council. We actually still need to work with OIT to get some video conferencing set up in that new space. So in the long term, in the future, it may be that we move over and start having the folks who attend in person meet us there in the small conference room that we'll have. But until you hear otherwise, if you're coming in person, you can still expect to find us here. And it may be that just logistically, it's still good to come to this building because it has very fancy equipment that we will not have over there. So we'll be playing that by ear. But yeah, just wanted to share that update. And it's really exciting to be creating a kind of a permanent home for the. So with that, I just wanted to move into. Oh, go ahead. Sorry, was somebody speaking? I thought I heard. Okay. So I'll move into the sort of more substantive part of the agenda now, which is a little bit of level setting. I think we mentioned wanting to do that at the last meeting, given new membership, to just kind of revisit the charge of the office. There we go. So I put together a few slides that pull in the language from statute that sort of, again, substantive on duties, not necessarily all of the administrative things and timeline and appointments and things like that, but really what speaks to the legislature's expectation of the office's activities, and split that into the two categories of work that'll really help I organize my thinking about the office's work. So the first of those being focused on analyses and tracking. Just as a reminder, the statute really focuses particularly on the office using data from the Maine Health Data Organization. I don't think that it's written in a way that is exclusive of other data sources, but specifically calls out both MHDO and Maine Quality Forum in terms of those being like primary data sources that the office is expected to kind of pull from and utilize. And it lays out a few different dimensions, I guess, of health analysis. The first being healthcare cost growth trends and correlation to the quality of healthcare. The second, which is a very long one, is essentially healthcare spending trends by a variety of categories, some of which are called out here, but it ends with saying, other aspects of the healthcare system that are sort of helpful for the legislative oversight committee to understand. So I think just speaking to the expectation is that we're not only looking at a totally aggregate statewide level, but trying to think about different ways of cutting that data and utilizing it to provide insights. And then finally, monitoring the adoption of alternative payment methods in the state and other states that foster innovative healthcare delivery and payment models to reduce healthcare cost growth and improve the quality of healthcare. So kind of three, I would say, somewhat intersecting but distinct areas that are called out in the statute that I just thought I would kind of walk through and that inform the way that we approach the work. Though again, there's not a lot of super specific detail here about exactly what these analyses are intended to look like. So I think a fair bit of discretion left to the office in terms of exactly what's produced. Then there's a second section of the statute that I categorize, this is my language, not from the statute, but as policy development that's a little more focused on not just taking data and analyzing it, but sort of what is done with the data from there. So there's a section that specifically refers to using the data, and I should have called this out a little bit more clearly in the way that I structured the slide, but the data and analysis from that first slide that I showed, produced by the office, again, somewhat specifically looking at MHDO and MQF data, to develop proposals to improve the cost-efficient provision of high-quality healthcare to the residents of the state, and then conduct a systemic review of the healthcare system and develop proposals to improve coordination, efficiency, and quality of the healthcare system. Again, the not sure how exactly the legislature thought about distinctions between these two categories. I think improving efficiency of the system has a lot of relationship to improving the cost-efficient provision of healthcare to residents of the state. But those are kind of the two categories that are specifically tied to that data analysis that the office is directed to do. There's additional language around developing proposals on methods to improve consumer experience with the healthcare system. And this language also specifically refers to provision of consumer advocacy functions that aren't addressed by the Health Insurance Consumer Assistance Program that's currently authorized in state law. We're additionally directed to provide staffing assistance to the Maine Prescription Drug Affordability Board. That is something that I know we don't talk a lot about in this group, in part because they are a separate body that we also staff and support. But just so folks know, they are a board also established in state law. Originally, that board was directed to establish spending targets on prescription drugs just for public purchasers, and then to essentially track how public purchasers were or were not meeting those spending targets and propose ideas to facilitate them meeting those requirements. But there was just a law passed this past session, went into law at the beginning of the session after the governor sort of declined to take action on it, which changes the charge of that group, and it is now tasked with looking more broadly at issues of prescription drug costs and affordability, and writing up a set of recommendations to bring back to the legislature by the end of 2027 with ideas for policy interventions that could lower prescription drug costs, make them more affordable, with that report being expected to also include considerations for implementation as well. So that is sort of a separate work stream in our office, is that we do kind of convene them and provide agendas and provide research and information to that group, along with obviously working with this advisory council that has a more broad charge. And then finally, there was additional language added in after the statute was first introduced or first made law, to analyze barriers to affordable healthcare and coverage, and develop proposals with potential methods to improve healthcare affordability and coverage for individuals and small businesses in the state. So a little bit more, I think, of a specific focus on affordability for consumers, which could be maybe assumed or somewhat interpreted from the original charge, but was made kind of, again, more direct and firm with the addition of that language. I've got one more slide and then I'm happy to pause on this, but just briefly to touch on advisory council duties that are included in the statute. It is very, very short. What statute says is the advisory council is a council to advise the office on matters affecting the cost of healthcare in this state. Because it is, quite high level in the early days, the group did come together and put together a charter. I guess charter, I just wanted to make sure I was using the right term, or organizational charter. I did realize I hadn't thought to add this when I sent the slides around, so I apologize for that. I should have flagged this earlier as something for folks to take a look at, but I wanted to add it in when, I kind of made the connection here to thinking about duties. That was something where, again, I don't think it adds a huge amount, but the group had kind of talked to the different ways that the advisory council can kind of organize its work, prioritize, think about what the role of members is. So I thought I would share that. And I think if folks want to take a look, we can in the next meeting to do a more deep dive kind of review and let folks bring up if they think that there are changes to that or if anyone has questions about that charter, but it may be helpful. And it has a few points as well on kind of organization, just sort of how we manage meetings, things like that. So that's the end of the section on just like a little bit of level setting. Like I said, especially for new members, I think helpful to check back in on the statute, just make sure everyone has a chance to absorb and digest a little bit about what the office was created by the legislature to do in the charge. But happy if folks have questions or thoughts on that to pause here for a minute. I can keep going. Okay, great. So then the other thing that we wanted to do, given the end of the session and our conversation at the last meeting, was just do a little bit of a update on legislation and talk a bit about kind of big picture future planning. So a few updates, and I organized this again by those 3 areas of policy focus that had been developed, over the last few years that we've kind of been working from for over a year now. So the first of those was provider market oversight and competition. You'll remember the office worked quite a bit on a bill last year that created a more comprehensive review process for a wide range of transactions involving healthcare providers. That bill was sort of rolled into a commission that a few of us served on throughout the fall. And out of that commission came a recommendation for a more narrow piece of legislation that built on the same structure that we had proposed and that we drew heavily from a NASH model from, as well as our conversations with some other states. But it really took that structure for review, but narrowed its focus to just acquisitions that involve essentially private equity, using a few different terms. If it's a management organization that is heavily owned by or influenced by private equity, that's wrapped in, but really that segment of transactions that I think folks felt kind of present the highest risk to the health system in terms of disruption or in terms of prioritization of financial motives over patient care motives. So that narrowed down bill, LD 2201, did pass and was signed by the governor during this past session. As I said, it creates a material change transaction review process, and we have some responsibilities under that law, some new responsibilities. We have a role in working with the Division of Licensing and Certification, DLC, and Maine DHHS when transactions come into them in terms of determining essentially level of risk and whether those transactions should receive a comprehensive review. There is an option under this law that they can be approved relatively quickly without an in-depth review if they are identified as not presenting a lot of risk or they don't need that deep review. But if we collectively determine that a comprehensive review is necessary, our office is also charged with conducting a cost and market impact analysis that kind of dives a little bit deeper than traditional certificate of need processes do and has more of a focus on broad patient impact. So thinking not just about what will the impact on cost to the Medicaid program be, but also what could be the impact on cost to people with commercial insurance or other forms of insurance and other risks, including things like equity. So we're really excited about that, but it will be a work stream for us in terms of probably assisting in rulemaking. We wouldn't be the lead agency on that, DHHS would be, but expect that we'll be quite engaged in that and obviously have a role in terms of thinking about kind of addressing some of the questions that came up really in the legislative debate about that. There is work to do around how do we think about concepts like metrics of affordability and what will that mean in terms of what applicants will be able to kind of expect or understand about the criteria that will be involved in their review. So We will be working on that, once that process starts, things kind of lock down and follow official processes in terms of comment, and we can certainly keep members updated on that process, but just wanted to give an overview. In terms of the work on regulating commercial prices for health services, obviously lots of conversation at the last meeting about LD 2196. After we spoke about it, there were some very significant changes to the bill that happened as it moved through the Health and Human Services Committee of the legislature. The version that they eventually voted out included only caps on the growth of hospital prices. So it didn't include any of the caps referenced to Medicare that we had discussed that would actually bring the price of hospital services down. It would just have limited the growth of hospital prices into the future. The provisions around prior authorization were removed in that version, but the floors for primary and behavioral health care were also significantly increased. So they would have increased each year until they reached 150% of the Medicare rate by 2034. That bill, unfortunately, from my perspective, was tabled in the House, meaning it just didn't receive a vote during the legislative session. And when that happens, it dies on adjournment. So that bill did not move forward. So then moving on to the last area of policy focus, which is really, the one that I sort of frame or talk about as being very much what is on my mind, our mind for the immediate future and the future in general, is the last category of work, aligning incentives to promote efficiency and quality. From the very beginning, when we talked about this area of policy work, I had flagged that I viewed this as less clearly a legislative kind of category or area, and potentially one that would be more focused on convening, on kind of problem solving, on thinking about maybe non-legislative paths forward to make some progress in this area, because it is one where I think there's a lot of alignment in principle, but the struggle, I think, is often moving that to practice. I can just briefly say, because I'm realizing that newer members, we haven't spent as much time on this, but really this is our category for thinking about opportunities for payment reform. What can we do, knowing that there's a lot of agreement that paying fee for service doesn't work well for providers, doesn't work great for payers, doesn't work great for patients, to try to transition away from that and try to transition towards models that are better for everyone. So I wanted to flag here, and I think I mentioned it in a meeting earlier this year, our work with the Rural Health Transformation Program as part of the team that's doing that work within the state, really being the kind of venue and path forward for some of this work. And you'll see this pop up a little later in the slides that Katie is going to present. But, this is a really large effort by the state. There are relevant staff, across the Department of Health and Human Services, across other departments that are really engaged. I think increasingly more and more engagement with external partners. And so, I think the folks that need to be part of conversations about aligning incentives are largely going to be part of that program. And I want to make sure that we're not, trying to run in a different direction or do something different. I want to find ways that we can kind of leverage that process and be thoughtful about the work and use it for a catalyst to really make some progress here. So that is, because it is so hard, is really an initiative that the Department of Health and Human Services is leading. So, and it involves a lot of involvement from CMS and other actors. So I want to continue sharing more about that as I'm able. There's a few kind of moving pieces now, but I'm hopeful that by the next time we meet, we can maybe do a little bit more of a substantive discussion about the activities and projects that we're engaging with on that. But I wanted to say, a few of the areas where I think we'll be contributing, where we'll be participating, is think about data analyses to understand availability of providers and services around the state. And again, that really intersects with what Katie is going to share. Think about leveraging our analyses of hospital financial performance and some of the conversations that we've had in this group about interpreting that information to help with informing the hospital financial stability and efficiency activity within RHTP, and supporting the planning stages of the regional health ecosystems activity, which is really about reassessing how care is delivered and paid for. Here I say in rural communities, but I should have said for rural residents, because it is broader than just thinking about specific geographies. And that's the one that I most want to flag. I think there's an opportunity there to be building towards some more big kind of imaginative, visionary conversations about health that I know there's an appetite for. In this group, of course, need to be realistic about that. 5 years of this grant sounds like a long time at the beginning, but now that I've been with the state for 7 at this point, maybe going on 8, you know, it's amazing how it flies by. So need to think about achievable goals in that time. But again, want to make sure that we're aligning there and contributing as much as we can to that effort rather than trying to pull in a different direction or asking for people's time when they're already being asked to contribute on this front. So I know many of you are probably engaged in some ways in this conversation, but increasingly will be. I just wanted to share it as very much a priority for me and something that I'm expecting will be taking a lot of the office's, you know, time and energy over certainly the next year and probably beyond that as well. Any questions on those slides? If not, I can hand over to Katie, who was going to give an update and talk a little bit about access and quality metrics and kind of revisit that conversation that we started earlier in the summer. Just briefly, before I hand it off, I wanted to do a little bit of big picture on this topic for a few different reasons. I think as we've talked about this with this group, as we've talked internally about this area, which I will say, you know, I'm pulling out because I think looking at the statute, there are some references to quality there. And it's something that we think about, but we certainly haven't done as much work around really defining what does that mean and how is that measured as we have on some of our spending analyses. A large part of that is, I think, when I came into the office, when the office was starting up, it was much easier and clearer to kind of look at MHDO's current work, scope of work, and identify places where we sort of felt like we had a research question and knew how we could get at answering a research question using the comprehensive, you know, or relatively comprehensive data that they have. I think with questions around access and quality, it's been a little bit more challenging because I think the data sources are more dispersed than they are on spending, where it really is, you know, a little bit easier to identify where we can be pulling data from, but also because there's more moving pieces, I think, in these areas. You'll see as Katie kind of walks through things, there are some places where there's a long-standing data source that we think is generally agreed upon and, you know, is helpful in thinking about these issues, but there's others where there's new work just starting up that we really want to make sure that we're not duplicating. So we're not quite yet able to say, this is going to be the data source or this will be the perfect data source, but we see a lot of opportunity there. But that part's just been uniquely challenging. The other piece that I just sort of wanted to see before I hand off the conversation that I think is helpful and that I myself am working on kind of internalizing on this work is, I think our purpose here is trying to think about measures at a high level, at a state level, that can be kind of combined or looked at in relationship to policy changes over time. So for example, the reason I say that is on quality in particular, that's probably the best example. I feel like from my prior work, from work that many of you do, right, like quality data collection and reporting is often the goal is to improve quality at the provider. So you're looking at a provider level, at a pretty granular level so that you can think about where there's opportunities for improvement or track performance or payment metrics, for example. I feel like it's a little less common to think about how do we think about quality at the state level, like measuring just the quality of our health system overall. So there's like a little tension there between the ways that we usually think about it, some of the data sources and why they are collected and how versus what I think we're trying to accomplish in this conversation. So I just wanted to flag that. I think, you know, welcome feedback as we go through and talk about that, but wanted folks to understand that that's the way that I think about it, because again, it is really different than, for example, Maine Quality Forum. I know some folks are probably very familiar, but you know, we have an entity here in the state of Maine that is tasked with measuring healthcare quality and again, improving it. So they're, I think, thinking of it more from a clinical perspective, really partnering with providers on certain metrics and have been thinking about how to use that for improvement. But I think our purpose is a little different because we actually, the goal at some point would be able to look at things in combination and be able to, at some level, kind of track, has a policy improved or harmed quality, or is there a correlation between these two things, which is just, a very different proposition. So it's been a tough one, and there are just also some limitations here, which Katie will get into, and we're trying to make sure we're being kind of realistic about what we can and can't do, because we're not looking to get into the business of like creating brand new surveys or trying to create new clinical metrics. So we're really trying to focus on what already exists and is reported that we can draw in and draw together that kind of creates a dashboard at a high level that can track some of these metrics, which we think is what the statute was kind of getting at. So with that, I will finally turn it over to Katie. Unless anyone has questions, please feel free to raise a hand or chime in if so, but otherwise I'll let her dive into the details.
Great. And thank you, Meg. As we work through these, please feel free to raise your hand or jump in as I go through some of these slides. I wanted to start off before the session. I want to say maybe one of our advisory council meetings last summer, we met to talk about measuring access and quality and went through a variety of different data sources and had a really robust discussion with you all. And I wanted to take a second to review what we did during that meeting, not only for the new members, but also just as a refresher for the members that were part of that meeting, and discuss, what did we talk about? What did we agree upon? What do we do as an office in the meantime, and where we're hoping to go? So just to start, in our last discussion, we talked about measuring access and quality of care as fitting into 4 separate buckets. And the first being coverage, who is limited to accessing care because of the type of health insurance they do or do not have, the types of services available, so what services are available in Maine and where are they located. That was a great discussion last time. We also talked a little bit about workforce. Is there enough workforce? What type of workforce does Maine need to meet the need of consumers? And then finally, timeliness, which is a combination of both. How are patients able to receive care, consumers able to receive care in the time they want or in a time frame they want, and access the type of care they want in that time frame. And then kind of throughout all of those access buckets, also thinking about quality, as Meg touched on, making sure that we're not just measuring access to any care, but wanting to also be able to understand or say something about the quality of that care. And in our last discussion and throughout this discussion, thinking about where we want to start in some of this reporting, really getting a sense of what data is available. And within the available data, we wanted to think about 4 different distinct qualities of those data sets. And first and foremost, the feasibility in getting and accessing the data. So wanting to make sure the data is something that we can access. It's not hidden behind a paywall, or it's not difficult to get in a timely manner. The second would be, we're really looking to find data that is historical and replicable. Thank you, that sounded wrong. So understanding, we want to be able to track changes over time and making sure that if we are going to invest our time in an analysis in a certain data source, wanting to make sure that that is going to be updated over time so that it has maximum value to this group and to others who may be looking at it. Also wanting to make sure our data sources are timely. As we all know, data sources can have significant publishing lags. And so trying to find data sources that are updated annually, or at least updated on some kind of consistent time frame that we can utilize and be able to track trends in the best manner possible. And then finally, thinking about data sources that are detailed and really allow us to understand from a broader view healthcare access in Maine and healthcare quality in Maine, and how those measures change depending on the different characteristics of the consumers or different demographics, whether it be geography, race, ethnicity, age, those types of things. So to provide a little bit of update on what we've done in the interim between our last meeting on measuring access and quality of care to now, is we took some time to meet with different organizations that are doing some of this work, including the Maine Health Data Organization, MHDO, as well as some researchers from the University of Southern Maine, and thinking about other state agencies who are doing this work to make sure we're not trying to duplicate any work, and also to be able to leverage the work that they are doing in that time. I just did want to note, there were some analyses that the advisory council had great engagement with last time. As you may remember, we showed a study conducted by USM on avoidable emergency department use. We did meet with that group. Unfortunately, that was kind of a standalone product that used a methodology that is not being updated at this time. And so just wanted to flag that. I know there was great engagement, and that's not something right now that we're able to kind of pick up and refresh, but definitely, you know, avoidable ED use and in those types of ideas are stuff that we, you know, be very interested in the future. We know there's a lot of energy right now in different organizations on ED boarding and data sources related to that. So we have not lost that idea. I promise we really appreciate the engagement there, but just wanted to provide an update that we did follow up and we weren't able to, you know, easily refresh that or pick that work up. And then I just want to say, you know, throughout this process, just wanting to note that, you know, annually updated data on healthcare access and quality is limited, and especially at the state level. I'm sure that's not news to anyone here. You all probably work in these measures more often than I do, but, you know, moving forward and as we go through the slides for where we're looking to go in the future, our initial steps and where we're hoping to move are really focused on the first steps that we can take with historical reproducible data that allows us to, you know, measure things over time and are not doing point in time analyses that we're not able to see trends. So just wanted to highlight that's our focus, at least moving forward in our first steps here. So jumping in first to that first bucket of coverage, last time we chatted, we talked a lot about our goal of monitoring uninsurance rates in Maine to understand coverage changes and the potential impacts on access to care. We mentioned during that conversation, we also talked about underinsurance and what it means that for individuals that do actually have health insurance, but maybe it's not comprehensive enough to get the care they need or the care that their provider thinks that they should be able to get. So we're going to start, you know, to report out on uninsurance rates by different demographics. But we're keeping that idea of underinsurance in our back pockets and thinking about maybe future steps there. But starting with uninsurance, we're thinking using the US Census. That's something we talked about last time. As you know, it comes out, they have 1 year estimates, it is reproducible. It's very easy to understand, I would say, for the majority of stakeholders, definitely for this group and for most consumers. And it's data that we have good information on across different demographics. So for example, here, I just pulled very quickly uninsurance rates in Maine and at the national level from 2017 to 2024 by different age groups. This is an example of something that we could put together as a dashboard and be able to monitor over time. What I think is, you know, helpful about this graph and, you know, a great thing for Maine is that Maine's uninsurance rate is below that of the national level for all of these age groups in recent years, which is exciting. Probably unsurprisingly, we see that, you know, our individuals 65 years and older have the lowest rates, followed by children, and then our working age population, 19 to 64, have some of the higher rates of uninsurance, but still below the national level here in Maine. I'll pause there, but this is an example, I would say, of something that we could do in the future very easily with readily available data. And again, is the first step in thinking about coverage, and maybe a second step is thinking about that underinsurance piece.
Just on that underinsurance piece before Katie moves on, I just want to call that one out as an area to particularly invite feedback from the advisory council members, you know, now or in the future, to put an extra fine point on it. This is one of those areas where we can certainly find sources, sometimes just for a segment of the market or a point in time. For example, we were able to work with the Urban Institute a couple of years ago, and they were able to do those projections that looked kind of in aggregate for us of the whole commercial market, what kind of total spend were leading households having to make on their healthcare. which are great, but that's an extra level of effort we were able to do at one time. It's not something where, at least right now, that is available on an annual basis. So I think I would just use a gut check, I guess, with this group if folks are aware of some data source that we may have missed that's both kind of comprehensible or reportable on an ongoing basis, or if advisory council members feel like underinsurance is so important that maybe we do want to pick a segment of the population where we can pull a metric. Like if we should be thinking about a priority group, the marketplace is one, for example. It is much easier given the amount of data that we have on that population to track things like the level of coverage that they're buying into and what their out-of-pocket costs might look like. So we can certainly think about that and would love folks' thoughts on that. But it's been a challenge to find something that is sort of covers the whole population at the state level, at least for commercial, again, because that's a little bit easier, but certainly like in the Medicare population, right? Thinking about how patient liability and sort of total coverage might vary between traditional Medicare and an Advantage plan adds an extra layer of complexity. But that's been our struggle. But I just wanted to speak to the understanding why that's a priority for this group and understand why that's such a priority for policymakers too. That in the environment that we're in right now, yes, coverage is really important question, but also the value of that coverage and how much protection it's providing is a really important one. Yeah, Katie?
Thank you. I really appreciate the thought that's going into that question related to underinsurance, because it's a very real issue, as everyone is aware. And two thoughts come to mind. One is we don't really have a definition of underinsurance, so that might be something that this group could tackle. I know when the ACA the original ACA bill did define the percentage of income, that the maximum percentage of income for people before subsidies kicked in, and that might be I think it was 9% or somewhere in that neighborhood. It might be something for us to think about, because I think that's part of the problem in measuring underinsurance is just how you define it. But the other place that I turn to is whether there is an opportunity to look at the bad debt that is accruing in the healthcare systems, hospital systems, and it's probably not limited to hospital systems, all of the providers, because that certainly reflects people's inability to afford the care. And that would be people who are not eligible for charity care if they're within the hospital systems. So that might be something we could create a data source for and measure over time.
Yeah, that's a great suggestion. I think we can definitely take a look at that, see if there's a way we can kind of aggregate up and then look at that longitudinally to look at trend over time and how that's changed maybe as a proportion of total spend. And that might be the way to do it so that we're adjusting a little bit for like regular changes in volume. So that's a great idea. Yeah, we'll take that back and give it some thought. Thank you. Kate Endy? I see your hand came down, but you didn't come off mute. Just double checking.
Sorry.
Okay.
And maybe this is, a conversation for later, but just kind of going off of what Katie was just talking about, I was wondering, do hospitals collect information on income of people that have bad debt? Because I think it's interesting to see the ages here. I think that's like another metric when thinking about like the landscape that could be important as well. I'm just curious if hospitals collected that or not.
I doubt that we formally collect the income of people who accrue bad debt, but they would all be above 200% of the poverty level. Right. So I think that's the important thing. And we can also understand, the amount of debt that they have, whether they're uninsured or underinsured, we would have that information. So I think, I'm not sure income level is as important in my mind, because some would be employed, some might be getting their insurance through the exchange, which would be two very different groups marketplace. since some would be paying their own premium, some wouldn't. I think we'd have to think through what what income level would tell us, but we know that they are accruing bad debt and that ultimately reflects on their credit scores, or it might. So that's something that most people try to avoid.
Yeah, and I think, it is a great question, Kate, because I guess as we think about trying to track some of these metrics from that equity perspective, understanding how burden is maybe falling across different household incomes in a perfect world would be helpful, but understand that's not always possible. But certainly, just to say your point, Kate, too, I think Katie just wanted to show this as one example by age, but certainly with the census data that this is pulled from, the data can, I think, be cut by at least categories of household income. It's always a little tricky to define the cutoffs, but I think that they've got, a few different kind of segments of household income. So that would be another way that this data source could be used, along with thinking about geography and I think racial and ethnic disparities as well. Yes, Representative Graham.
Yeah, thanks. Thanks, Meg. Looking at this data and looking that it's retrospective, looking the last numbers, and this is well done in 2024, but we are anticipating a severe increase in uninsured patients, with the changes in the ACA and the cuts in Medicare in main care. And so I wondered if there's any way to look at prospective data, partnering with like Kaiser or other national organizations who are looking at, look what's happening, because we are looking at people to be not able to afford insurance, and it's going to go through the roof. And so I just don't know if there's any ways that we can kind of look at that prospectively.
Yeah, I think I kind of separated into two work streams. I think for the purposes of this presentation, what we were thinking about was kind of creating a set of metrics that they could be monitoring on an ongoing basis, because I do think, for example, into the future, it's great if we have this baseline, and if we can help, I'm sure others will be thinking and talking about and using particularly on this measure, focusing on it, but kind of reminding people that we have these sources and we can watch what happens when policies like the policies at the federal level are enacted, and see the impact that has in terms of coverage. The uninsured rate drop here that was associated with continuous enrollment on Medicaid is really interesting, along with changes resulting from the expansion of Medicaid in the state too. So I think we see that reflected. In terms of the future looking work, I can say, we probably within the office don't have the capacity to do that. We certainly can and actually have partnered with national organizations. We did that with the Urban Institute when the office started, where they projected out into, at that time, they were projecting, I think, into 25 or 26. So it's been strange to find ourselves in that moment for us, where they were looking both at changes in coverage, but also helping us a little bit with some of those analyses, again, that can draw from multiple data sources and tell a more comprehensive story about things like what is the percent of income that Maine households are being expected to spend on all of their healthcare costs instead of premiums alone, for example. So we did do that, but it's just difficult to kind of do that on an ongoing basis. And I think in this particular moment, certainly, I think if others in the state were undertaking some of that work, I'd welcome the chance to step in. But in terms of changes from the federal level recently, DHHS, given that they house both the Medicaid program and the marketplace here, I should say Maine here in this context, but the marketplace CoverMe.gov as well too, they did do work, through last spring and summer and fall, where they were creating projections of impact from federal law. So I'm always happy to collaborate with them or think about it if there's ways we can work together to share that work or to refresh it now that the law has passed. But we did sort of defer to them on that because, among other things, the granularity of data that they have on marketplace consumers by, for example, income, and being able to identify who had qualified for enhanced subsidies and who had not, and that they have on Maine care enrollees too, is just much more than we naturally have access to, and much easier for them to do those analyses than to go through the process to grant us access to that data for us to work with it. So always happy to undertake those analyses if there is a gap that's identified, but we can also, turn to them and happy to think about how that work can, inform the future or inform folks as we see these changes, gradually roll out. Obviously, now we're already in a world in which the enhanced premium tax credits were ended, and where there definitely was an impact seen in terms of enrollment in the marketplace in 2026, and those Medicaid changes are on the horizon as well. So I think expect to see changes there. But I guess for the purposes of this, I view this exercise as sort of thinking more about how can we track that using, rather than projections, the actual data, and kind of validate or maybe upend in some cases expectations about policy's impact on these factors in the state. Yeah, Amanda?
So when I was reviewing these slides last night, I know you mentioned the Behavioral Risk Factor and Surveillance Survey, or BRFIS, in future slides. I've done some work analyzing insurance and uninsurance in working age adults, and then within those subgroups, looking at affordability and access variables. So I haven't done a deep dive into a BRFIS codebook in about 5 years, but I don't know if that is a source that you guys have considered for kind of these under-insurance type questions, or if that's, a data source that you've run into issues with or enjoyed working with in the past.
Yeah, I'm happy to take it. Absolutely. Thank you so much for your contribution here. We do in the state have access to the main respondents for the BRFIS survey, which is fantastic. And if I would say welcome, if you have an idea for a methodology or an idea for a process on how we can leverage those data, which we do believe we'd be able to get, annually and, over time, update in looking at things like underinsurance, I would absolutely welcome that. Unless,
I can send you some kind of old work that I've done at this point. And then as we continue to be thought partners, maybe I'll keep that in the front of my mind.
Perfect. Yeah, I was just going to say, I know at times we had difficulty. There are areas where there's blurring of the lines between these categories. So I think BRFIS is in the section we put in access, and there's that question about how recently someone has used care, I think, and why. And certainly I'm thinking, well, for the people who answered that it had to do with cost, if we could cross tab to their answers about insurance status, maybe there's a way to dig in there. But I think we've gone back and forth on that and where it would land, and ended up putting it in access, but no reason we couldn't think about using that data differently to expand the coverage category too. That sounds great.
Absolutely. Thank you. So happy to move on, but welcome the discussion as we continue to move forward. Our next bucket area is services. And the last time we chatted, there was a robust discussion and excitement around the idea of being able to quantify and really understand the current state, and then hopefully be able to track in the future of service availability in Maine. And this really breaks down into not just what services are available, but where are they available. Within our last discussion, we talked about that affordable ED use paper that I think had a lot of excitement around. And again, happy to kind of pick that up or think about that in the future, but wanting to start in a place that we think was able to be reproducible. We found that there's really not a lot of consistent data in this area. So we wanted to be able to turn and leverage some of the work of MHDO. They're funded by the Rural Health Transformation Program to develop a centralized provider directory that can be used in combination with other data sources to be able to track service availability over time. And we think this is, again, a good first step on not wanting to reproduce efforts, but be able to leverage something that may be really helpful in understanding what providers are available in Maine and where are they available. So there is an anticipated MHO provider database here. And some of the additional considerations we're thinking about is just, prior work in this area, as we said, with the affordable ED use has been more of a point in time as opposed to we're looking for, which is more reproducible. And we're also very open to suggestions here and other approaches. I know last time we spoke, members brought up the idea of being able to track some of the post-hospital acute and long-term care facilities, including nursing homes, skilled rehab, and home health services. We're more than eager to do that, but looking to this group and others if there's data sources that are robust and consistent in this area that we could leverage. Katie, I see your hands up.
Thank you. I think this is really important, and I wish I could share a great data source. I think this is going to be a challenge, and I would just encourage you to be looking not just at what sort of who the providers are in different places, but which patients they take as well. So do they take all patients regardless of ability to pay? Do they pick and choose sort of some of their patient panels? Because access really is, to your point previously, it's about coverage, it's about and about provider availability. So we need to marry those two together.
Thank you. Absolutely. Happy to consider that and thinking about, what patients are able to get in different areas.
Yep, yeah, and I would just say agree that this is one of the areas where we're not thinking of drawing from an existing data source, but I think there has been recognition that this is information that's going to be very helpful for the rural health transformation work. I might start saying RHTP because that's what we say internally. So if you hear that acronym, that's what I'm referring to, but generally for kind of health system planning. So I think this is going to be quite an effort on MHDO's part, but really glad to have them working on this and tackling it. And I think it'll be really valuable for our work and for the broader work of the department and others on that project and on others. So grateful. It's good timing to work through that together. Yeah, Representative Graham?
Yeah, just real quickly, I think it's very important about how people are paying. There are increasing amounts of practices that are not accepting certain insurance products. I know Intermed does not take MaineCare, and they have just said that they are not going to take Martin's Point any longer. I think that's a real concern. I know that in the greater Portland area, access to services is a little easier, but I think that that certainly we need to be clear about what practices and what providers are taking, what type of payment they're taking, if they're refusing to take certain types of payment.
Yeah, no, point well taken. There definitely been in thinking about service availability if there are large categories of folks that aren't able to utilize a given facility or practice. That's important. So we're going to be glad to take that back to the team and see if in the kind of process and methods that they're going to be undertaking to create this, if there's an opportunity to check on some of that. It starts to get complicated, right? I think about how complicated it would be if we were trying to have, for example, integrated particular insurance network participation. But I think if there's, wholesale sort of exclusion in particular, we have some of the big public payers, there's probably a line we can draw there that's feasible, hopefully. So yeah, thank you to both of you for that suggestion. I think it's a great one.
Absolutely. And so moving forward in this section, as Meg said, working and following the progress of MHDO, happy to, as we just did, consider bringing, thoughts to that process as the council and as our office thinks that it would be helpful for them. But here, we won't come out with anything, I would say, in the next couple of weeks for this area, but, this is our plan moving forward and look forward to collaborating with MHDO. Next is another area I would say that was difficult to find data that was consistent and reproducible. So that would be workforce. And our goal really here is to be able to monitor and report out on workforce status and demand in the state. The last time we touched base, I know there was, again, a great discussion on some of the national data sources, like HRSA looked at health professional shortage areas and things like that. Based on our discussion, it seemed like the advisory council and others were, potentially just had some concerns about those data sources and their applicability to Maine. And so during that time, we were able to kind of pause and look at what different organizations in Maine are doing to collect this data. I would say, like, first and foremost, if any advisory council members has a great data source on how you can measure and track workforce, happy to take you up on that. In the meantime, I will say MHDO was recently granted funding from NEHAP for a project to develop a standardized minimum data set for healthcare workforce and produce a comprehensive healthcare workforce dashboard. This might be similar to the services category, an area where we, look to follow that data and, be able to kind of sit as a fly on the wall or help with, thinking about how that can best be used and leverage that into the future. So we anticipate potentially using this data source from the Maine Health Data Organization. But again, if any advisory council members have some, great data source that is waiting in the hallways, we'd be happy to bring it into the conversation.
Yeah, and I was just going to add, obviously, this is very much in Karen Lee Harrington's wheelhouse. We're really kind of pulling from brief conversations we've had with her and presentations that we've seen her give to some of her councils here. But I know she, I think, mentioned nursing survey data as maybe a bit of a model for this. So I think the idea here was to think about kind of survey methodology, but one that's well integrated into, practice and licensure or certification in ways that can try to collect it as comprehensively as possible. But just to add a little bit more about, I think, the direction that Steve, and I think they were planning to kick that off this summer. So not sure of the exact timeline, but I know it's getting going soon. So certainly some lead time on this, especially until I'm sure data will actually be, collected, and we'll have some time to follow it. But again, just I think a really exciting development on one of these questions where we've sort of been searching for a couple of years, and I think come up empty. So I'm happy on this count to also have something to look forward to that I think will be really informative for policymakers.
And I will also mention another area that we will update you is we did reach out to the Maine Department of Labor as an organization that collects some of this data, and there might be an opportunity there as well to be able to project some of these things. But for right now, focusing on some of the work that MHDO is doing. And then finally, our last, category of access to care, thinking about timeliness. And the goal really here is to monitor and report out on measures that capture a consumer's ability to access timely care and the care that they, are seeking in that time. Our goal, or right now, thinking about the data sources available to us, a lot of this is patient-reported experiences, either through surveys like the Behavioral Risk Factor Surveillance System survey, BRFIS, and CMS also collects information on timeliness related primarily to patients in emergency departments, and we're able to very easily access that data and report out. For example, wait times, or pausing. The next area that we're looking to go into after we, start with reporting on ED wait times and patient responses would be wait times for appointments by specialty, considering things like primary care and how long it may take consumers to access a primary care appointment. And then also thinking about some of the downstream provider deficits leading to ED boarding. And again, that is an area that MHDO and others have talked about collecting data and reporting out on that, and something that we are closely monitoring. But an example of data that we do have would be from CMS, we're able to capture the average time all patients spend in the emergency departments at Maine hospitals compared to national hospitals. This is reported in minutes here. This is something that we don't have a lot of historic data on, but could measure moving forward. As you can see here, average wait times, and this is the total time that all patients spend in the emergency department before they either leave the emergency department or are admitted to the hospital. In Maine and the national average, they're very similar. It's just under about 3 hours in 2024 and 2025. So Maine looks, very similar to the national average on this metric. Again, this is something that is easily, able to be picked up and move forward. But we also note that, timeliness is far beyond that of the hospitals in the state. And we know that there are a lot of things that impact a patient's ability to move in and out of the emergency department, as that's a high demand area depending where you are in the state. So other areas that we're able, let me pause here. You can also see how Maine matches up to other states in the nation on this metric here. Maine is, middle to upper of the pack here. And again, something that we can measure over time and compare this kind of more statewide metric to other states and the nation. But beyond emergency department timeliness, as Amanda brought up earlier, we can also look at responses from the Maine Behavioral Risk Factor Surveillance System. And here I just pulled out one question of, I would say, a handful of questions that get at access and quality of care. This question that respondents can respond to is, other than cost, have you delayed medical care in the past 12 months for any of the following reasons? So participants or survey respondents were able to respond to any of these that applied to them. The most common response, Erin, Sarah, besides I don't know, or they choose not to respond to this question, was that they couldn't receive an appointment soon enough. And so I think that really gets at the idea of timeliness, and being able to measure these metrics over time will give us a sense of how Maine consumers and Maine patients are accessing care, and if they're doing it in a time frame that works for them. Other common, or I would say not super commonly reported responses, but the second highest there is that they didn't have transportation, which I know is another barrier to access that we see across more of the rural areas of the state in Maine, and something to be keyed in on over time. And then finally, just wanting to talk a bit about quality, and specifically thinking about, our goal within the office is to be able to monitor, report out on measures that capture the clinical quality of care. As Meg mentioned earlier, what this looks like in the office is a little bit different than thinking at the provider level or the patient-provider experience level. And so our plan is to continue collaborating with the Maine Quality Forum and its advisory bodies, specifically the newly established Primary Care Advisory Council, to identify opportunities for state-level reporting and quality metrics that capture non-hospital care. Data source here is to be determined as we continue, again, not wanting to duplicate efforts there, but think about how we can maybe pull out certain measures or think about how to measure, more global quality over time. And then finally, for those who are interested in more of these clinical quality measures, MHDO, through their Compare Maine website, does report out on quality measures, and these include patient-reported experience, surveys, things like falls and injuries, things like healthcare-associated infections and serious complications, so things that are, attributed or acquired within a healthcare setting, and unplanned hospital readmissions. The figure on the right shows the Compare Maine website scale. And so while consumers are clicking through Compare Maine, they can actually see some of these star ratings from CMS or some of these other quality metrics as they consider or shop for care. So this is an example, I would say, of the quality metrics that are being collected at the state level through MQF and MHDO. And we're continuing to think about how we can support these or apply these to more of our broader vision here in the office.
Yeah, and on that one, I'll just add, I know we've chatted a bit with Karen Lee about MQF's work, and I do think there are some, reports and other uses of the data that they have beyond just Compare Maine, particularly in terms of their leadership on clinical quality improvement initiatives too that they've done. But in talking with Karen Lee, I think, in the past, she was saying there was a lot of focus on hospitals, in part, I think, because of the robustness and sort of standardization of data that might not exist in a lot of other settings. And I think just to do with MQF's, priorities for improvement. But I think they are interested, and particularly this Primary Care Advisory Council, which we are not a member of, but we always sort of join and listen in on because there is a lot of shared interest with that group, is interested in thinking about, what does quality look like more broadly, and how can it be measured? How can they think about that in their own efforts as well? So I think there may be some opportunities either to sort of follow, MQF's lead on that and work that may be coming out of that advisory council, or to understand a little bit better what they do and don't plan to do, and see if there's other ways that we could collaborate and come together on thinking about a few metrics of this. But just wanted to really emphasize, we certainly don't want to be thinking only about some of these hospital-focused clinical measures. I think in terms of the statute and what we're thinking about, there's much broader, and especially, I think part of quality of clinical care is like, how well are we doing in preventing disease from progressing to a level where people are hospitalized to begin with? So again, but definitely a challenging conversation. I have in past roles tried to tackle this, just in terms of a single state's Medicaid program, thinking about what quality means to them, and that in and of itself can be really hard. So trying to think about it at a state level is a big challenge. But we want to, see where that Primary Care Advisory Council conversation goes, and then think about our next steps on this front. Yes, Dr. Evans, I see your hand is up.
Yeah, well, a couple of comments. One, I think this is a very good presentation, but I wanted to circle back to the concerns around access and timeliness. Those are age-old problems that often revert back to the workforce, especially in rural areas. So I think when we look at this, take a deep dive, you're going to have to look at the workforce from the perspective of not only employed physicians, but also of independent practice physicians. And I've been on both sides of that structure. It seems to me that a lot of times we get sidetracked with the brick and mortar aspects, rather than you can't just keep building places to provide care without having the workforce structure in place. So for years, we've always talked about recruitment and retention. I think that we're at the point where we need to reorder that and look at retention first, as opposed with the recruitment as the follow-on or backups. I will be attending the American Medical Association meeting here in a couple of weeks, and so we're going to be talking about a lot of these same issues.
Great. Yeah, and I think to speak to your first point on thinking outside the brick and mortar, I will say that I know the intent of that MHDO provider database is also to think beyond sort of, primary location, to try to include some ways of capturing things like availability of telehealth and availability of mobile units. So I know that's only part, I know you were focused on the workforce piece as well, and that's an added dimension, but it was just a good reminder that I think, the value of that will be, there's so much, we can go so far with things like NPIs and, trying to map from addresses and databases, but I think they're trying to do something a little bit more holistic that gets beyond that sort of black and white data and captures some of those different ways of providing care. And then I think it's a really important or an interesting point on workforce. My one question would be, I think, so much of the concern, I think, in Maine is about the aging of the workforce, that it feels like there's, retention in terms of not losing folks to maybe other careers because of burnout or other factors, or leaving the state, but also that challenge of just, folks being ready to end their professional careers and thinking about that. So my understanding, again, it's very rough because we're not the lead on the project, but I think the idea of kind of using a survey process to get at that is to understand a little bit more about the demographics of workforce, so that we can view those questions. I remember apparently giving the example of with nursing, that folks for a while were saying like, there's enough nurses in Maine, we've got enough, but not looking at the ages of those nurses and how that was going up and up each year, and sort of maybe not preparing or seeing the future there. So I think that component can be helpful too, like not just understanding a number for workforce, but trying to understand a little bit better who are those people and what kind of how can we think about them a little bit more as individuals and their needs and things. So a lot to think about for sure.
Thank you.
Oh yeah, really.
So our next steps, just to kind of conclude this segment, is we're going to begin building out the reporting on some of the, especially thinking about like coverage and uninsurance through census data. We can very easily, put that together and start building out our capacity for that reporting. We'll start, as we said, with easily reproducible and accessible metrics, but, keep in mind some of the, more complex things to measure and see how we can, put in systems to be able to better get at those in the future. And then the goal is to bring back these products to the advisory council for review and eventually, get it into a space that we can, share it more broadly as we, get that building out of that reporting.
And I'll just add on to that in terms of thinking about what the final product of this looks like. I've had a few thoughts, and I guess I shouldn't say final product, like to begin with. I think any kind of final product is a long way off, given that there's some big initiatives that we've touched on here. I think what I'm hoping is that kind of by the end of the year, so before we're reporting back to the legislature again with our annual report, we can, to Katie's point, have a set of identified metrics that we already have access to and can collect and kind of create a baseline with those that we can share with folks and explain why we've chosen them and why we think they're important, and then probably give them a preview and say, here are 3 or 4 more areas where we're sort of actively working because we've identified that there is a genuine gap in terms of what data is available and how useful it is, to try to kind of work collaboratively with our colleagues in the state to begin filling that for a variety of purposes. So just so folks know kind of what it is that we're driving towards, it feels very different than some of our dashboards, for example, where we had a kind of clear idea and like a publishing schedule. Although I will say similarly, I think about it in the same way we did those, that none of them are intended to be like a complete standalone product. They're all sort of intended to build on one another and begin to create a fuller picture. And I also think in the long term, in a perfect world, like I said, we want to think about how can the data all be drawn together? How can we think about the relationship between what we see in trends of spending over time and some of these other metrics? But it feels like creating some prioritization and identifying the data sources is kind of step one before we can move towards that. Okay. And I was just going to say, if we're moving into the other section, I just want to pause in case anyone else had feedback or other questions on that. Realizing I think we're close to time, so I'll hand it back to you.
So to wrap up today, we just wanted to provide an update on our non-hospital payment and utilization dashboards. So as you may remember, we've done a lot of work in hospital payment and utilization dashboards and the like. Today, we're happy to announce that we are, within the final steps of posting our non-hospital payment utilization and dashboards, but wanted to be able to provide time to review those with the advisory council today and gather any feedback that you may have over these dashboards. And I will follow up with where these dashboards are posted, but just want to take the time today to click through them with you all and kind of show you the functionality. Just click on, get this moving. Need to reshare.
Oh yeah, because it's a different window.
Thank you. Hold on just 1 second.
Pull it into a different tab so you don't have my 500.
Thank you.
I always forget this is the tricky part of doing demos.
Yes. Thank you so much. So just to talk about orienting ourselves to the dashboards, these, similar to our other dashboards, focus on 3 key metrics, which are total payments, utilization, and then payments per unit. On the pages, what you'll see here, the left side graph will be the metric that you chose from 2018 to 2024, and then the graphic on the right will show cumulative change in that metric. The different lines represent the different payers. So up top, you're actually able to click into the payers and choose either commercial, main care, Medicare, dual eligible, or commercial and Medicare. For the purposes of today, just to make things easy to look at, I'll just choose our common payers that we talked about, which are commercial payers, Medicare, and main care, which is Maine's Medicaid program. On the far left-hand side, under setting type, you can see that we've put a variety of non-hospital setting types here. I'm showing here ambulatory surgical centers, but we have a variety of setting types, including federally qualified health centers, office visits, primary care office visits, rural health clinics, urgent care facilities, and others. And then all the way to the right, you can also filter by the type of bill, which we've done in the past, which you can see here. For the purposes of this demonstration, I'll keep it just on all bill types, but as you may remember in the past, we've broken up bill types into institutional and non-institutional, and that just is really an indicator of the type of form that the claim is submitted on. And institutional often come from facility forms, hospitals, or other providers, and non-institutional usually comes from a non-hospital setting or non-facility setting. So just to provide those two differences. But for the purposes of these dashboards, we also provide an all bill type to keep things simple. So what we can see here is, just to describe, you can see that commercial and Medicare have the greatest total payments across the years in ambulatory surgical centers, and main care has a much smaller or much lower total payments. But when we actually look over time and cumulative percent change in these total payments, we can see that our main care actually showed, some of the greatest increases, but across all 3 payers, total payments have increased over the course of this time period. We can then look at what utilization looks like in this setting. So clicking in here, and let me just filter the payers. All right.
Sorry, the touchpad on my laptop is also
very
a little
different than mine. Yeah. So looking at utilization, again, on the left, we're going to just see utilization counts. On the right, we'll see cumulative change in utilization. What we can see here is that utilization is greatest at ambulatory surgical centers among the Medicare population. This may not be surprising to most of you, given the Medicare population is often older and has, a greater use of things like knee and hip surgeries. Then we see commercial has the second most utilization, followed by main care. Over time, what we actually see is that main care has a greater increase in utilization over time, and that commercial and Medicare have somewhat stable, slightly decreasing, slightly increasing over time, but generally stable utilization. And then finally, we can go to our metric of payments per unit. And again, this is the average payments per unit of service. So in this case, it would be per unit provided of ambulatory surgical center services across these 3 payers. And what we can see here is, similar to conclusions we've drawn in the hospital setting, we see that commercial payers have the highest payments per unit, and that our Medicare and main care payers have very similar payments per unit over time. But then when you look at the cumulative change, payments per unit have increased across all 3 of these payers in the ambulatory surgical center. So this is an example of something that you can look at with these dashboards. You can click into other setting types and see different trends, but just wanted to provide, space and time for the advisory council to, review these, give some thoughts. I know last time, before Katie, you'll jump in, I just want to note that last time we talked, I know that Katie, you brought up some, you had an analyst look at some of the methodology of these. We were able to bring back those comments to the MHDO and HSRI team and incorporate them into this design. So we are, feeling really good about the methodology, but I'll also share the methodology notes to the council when we follow up. Yes, Katie.
No, I really appreciate that. So I'm going to ask a really naive question, but is the MHDO collecting the same data set from FQHCs, from small private practices, et cetera, that they collect from hospitals?
So for the purposes of these dashboards use the all-payer claims database, which are claims submitted by insurance carriers for the services provided. So when we create these dashboards, whether it's the hospital dashboards or whether it's the non-hospital dashboards, we're still pulling from the APCD and just identifying if the service was provided in a hospital setting or a non-hospital setting. And then if a non-hospital setting, what type of setting that was provided in.
So you are confident that you're able, without having their data set, that you're able to parse that out accurately in terms of the setting, the type of setting?
Yes, so these dashboards were used the data set from MHDO and HSRI. They put these dashboards together. This was not us using their data set. This is us, working to leverage them.
Okay, thanks.
Yeah, and they use, those codes of taxonomy that we had shared, plus, additional validations and data cleaning methods. So I think, I will say it has the same caveats that any of our work with the APCD does, which is that not all payers submit, thanks to the Supreme Court. There's not the ability to compel them to. So certainly there are gaps. But that being said, we did think about volume here because we know that volume's a lot smaller. That's part of the reason that we started with hospitals to begin with, was we knew that we would have a good, strong volume. It was much easier to define. And I think if you hover over some of the data points, you can actually see volume of claims that were considered. And we tried to be thoughtful about places. I think there were a few examples where data suppressed for certain payers in certain settings because the data volume was just so low that we didn't have a lot of confidence there. But that's, just an extra level of information about like what's being inputted and what's being considered in these trend lines over time.
So happy to follow up this meeting with the link to these dashboards and give a sense of the methodology as well. Happy to take any feedback and any insights that you may have over that time, and look forward to putting these up on the website. Yes, Katie.
Sorry, one more clarifying question. For ambulatory surgical centers, are these ASCs that are not that do not fall under a hospital license? Are they solely ASCs that do not fall under a hospital license?
That's a great question. The ambulatory surgical centers were identified based on the place of bill type, and it's a number on the bills and claims submitted. I'm happy to follow up with the HSRI and MHDO team to see how that may change if the hospital, like if there's a different number for ASCs, if they have a hospital license, and can get back to you. But these were identified independently of hospital affiliation, really just based on the number for the place of bill type on the claim.
Yeah, so I think I'm going to make a pretty sure statement so that Katie doesn't have to, since she's the authority. I think that ASCs, even if they are under a hospital license, would be in these dashboards, because we were pretty careful in the hospital dashboards about thinking about the intersection of the actual place of service. So I will let Katie double check, and I will admit that I may be incorrect about that, but based on the conversations, I think that was where we were.
Yeah. But happy to follow up. Great. So if there are no other questions, I can stop sharing this. And I think we are at the end of our deck.
Yeah, so thank you for the patience. I know that set of dashboards took a particularly long time. That was one where we kind of kept on running into data questions, and particularly like the classification classification exercise was one that was a little bit of a challenge to think about what's the right level of category here, what do we and don't we want to include in different settings, but I think is a nice addition to the suite of dashboards that we have, and I think we'll certainly be thinking as a next step about kind of are there ways to bring the different dashboards together, or think about kind of how they contribute or how they inform the broader discussion, but really helpful to at least kind of have a baseline out there that is broader and looking at, I think the majority of kind of setting types that people think of when they think about healthcare delivery, particularly from an affordability perspective. So yeah, welcome thoughts. I think maybe if we can, when we follow up, we can kind of set a timeline. Like I said, when I shared the slides and the link originally, these are live in the sense that they're available in Tableau via the link, but we haven't published these to our website yet. We wanted to give folks time to be take another look and let us know if there's questions that you identify or concerns. So we can kind of set a timeline of maybe several weeks to give people time to dive into those if they'd like them, and then we'll be adding them to the suite of dashboards that are on our website. Like Katie said, that was the end of our agenda. So any other questions, items from advisory council members? Right. Great. Well, thank you all, as always, for getting together. Great to chat with you, and look forward to our next meeting and conversation. But in the meantime, you know where to find us. And like I said, I'll keep everyone updated on next steps as they relate to Katie and Kaylee, and where they're headed and recruiting for the office too. Thanks again. Have a great afternoon.